Hello everyone. Today we're going to discuss chronic CAD and we'd be focusing on the ACC AHA guidelines. I've used Notebook LLM to make most of the illustrations and the video presentations as well. To begin with, chronic CAD management guidelines include general treatment approach, GDMT and lifestyle, medical therapy to reduce events and symptoms, diagnostic evaluation and management, revascularization, PCI versus CABG, and special populations. As you notice, revascularization is one of the management strategies, not the management strategy. Goals of treatment are to prolong survival, improve quality of life, reduce cardiac death, and reduce non-fatal ischemic events. The key principles are this is a team-based care involving a heart team, patient-centered approach. There should be shared decision-making so that patient goals are satisfied. Consider the social determinants of health. A full third of cardiovascular mortality is determined by social determinants. Consider cost-value recommendations and follow the patients up in the clinic, at least annually. Risk stratification of the patients, we should incorporate all available information, use validated risk scores, classify yearly risk, low risk being less than 1% mortality, intermediate 1 to 3, high more than 3. Optimize GDMT. For cardiac diagnostic imaging guidelines, which include coronary CT, stress echo, stress nuclear, PET stress, dobutamine stress echo, stress MRI, and MAGA scan, will be discussed. Indications for testing and clinical scenarios will be addressed. Risk stratification assessment tools will be looked at, and AUC will be briefly looked over. For cardiac diagnostic imaging, these are the modalities. I just listed them out for you. For coronary disease, patients that have angina are categorized into symptomatic patients with intermediate or high test probability, asymptomatic patients with EKG abnormalities, pathological Q waves, left bundle branch block morphology, post-revascularization follow-up patients who are asymptomatic high risk, but more than 2 years post-PCI or CABG, those with inconclusive tests like an indeterminate CTA, intermediate Duke score, or intermediate stress imaging. All of these should be considered for cardiac diagnostic imaging. For preoperative evaluation, if someone has intermediate or high risk surgery and is unable to walk more than 4 minutes and has no stress test in a year, they qualify for further imaging. If they have risk factors like ischemic heart disease, congestive heart failure, cerebrovascular disease, they're on insulin, or their creatinine is more than 2, they should be considered for imaging. For transplantation planning, such as organ transplants, stem cell transplants, if they haven't had conclusive evaluation in the last year, they should be evaluated as well. Specific cardiac conditions such as new onset heart failure, either systolic or diastolic, with suspicion of ischemia, viability assessment when the EF is less than or equal to 50%, ventricular arrhythmia, sustained VTAC, VFib, non-sustained VTAC, frequent PVCs when exercise EKG cannot be performed, heart valve evaluation before surgery intervention, and etiology of mitral regurgitation, pre-TAVR assessment, all of these qualify. Patients that have coronary anomalies or aneurysms to assess their hemodynamic significance. The risk stratification assessment tools include the 10-year absolute risk calculator, Diamond Forrester table for angina classification, functionality of obstructive coronary disease, and the Duke treadmill score. All of these are different kinds of risk stratification. Some of them involve history, some of them involve assessing patient past history, some involve angiography, and some involve stress testing. The 10-year absolute risk calculator assigns low risk to patients with less than 10% probability, moderate for those with 10 to 20, and high risk more than 20%. The Diamond Forrester table has 3 characteristics. You look at substernal chest pain, exertion-provoked symptoms, rest-relieved symptoms. If all 3 are present, this is typical angina. If 2 are present, it's atypical angina. If 0 to 1 characteristics, it's non-anginal chest pain. There are several other such mechanisms. On angiography, if someone's found to have obstructive disease, whether it's significant or not, is assessed by angiography if it's more than or equal to 70%. Intermediate lesions, 50 to 69%. The functional significance is assessed using FFR or IFR or findings on a stress test. Cutoff values for FFR and IFR are 0.8 and 0.89 respectively. The Duke treadmill score is a simple test that comes from a treadmill stress test. The formula is exercise test minus 5 times ST deviation millimeters minus 4 times angina score. Risk categories are low when the treadmill score is greater than or equal to +5, intermediate for -10 to +4, high risk if it is less than or equal to -11. Here's a quick presentation generated by Notebook LLM.
All right, today we're going to dive right into the heart of managing chronic coronary disease, or CCD. We're breaking down an absolutely critical skill, how to accurately figure out a patient's risk so you can build the most effective treatment plan possible. Here's the thing. People are living longer, they're surviving initial heart attacks, and because of that, the number of patients with chronic coronary disease is just exploding. It's a huge problem, and honestly, it often flies under the radar, which means a lot of people just aren't getting the care they really need.
So let's picture this. A patient walks into your clinic. They're complaining about chest pain, but it's predictable. It only happens when they exert themselves. Now, the first question is obvious, right? Is this coming from the heart? But the real question, the one that truly matters for their future, is this. What is this patient's long-term risk of a heart attack or something worse? Answering that is the absolute key to managing them correctly.
So here's our game plan for this explainer. We're going to start with that initial patient workup, then we'll move into how we actually unveil their risk using testing, how to translate those test results into a solid plan, and finally, we'll talk about the end goal, truly personalized long-term care. Okay, first things first. It all starts with the basics. In this initial workup, we're basically detectives, gathering those first crucial clues about what's really going on with our patient. The classic symptom, the one you'll see all the time, is stable angina. And let's be clear, this isn't just any chest pain. It has a specific pattern. It's this temporary discomfort that pops up with a predictable trigger, like walking up a steep hill, and then it goes away with rest. That pattern is the classic calling card of myocardial ischemia, where the heart muscle just isn't getting enough blood flow.
To really understand what's going on, a good patient history is everything. So what are the essential, must-ask questions we need to hit every single time we see one of these patients?
This table really boils down the clinical guidelines into 4 key areas. See, we're not just asking about pain. We're trying to understand their function, right? We're checking if they're actually taking their meds, and we're looking for red flags, like a recent trip to the ER. This systematic approach just paints a much clearer picture of how stable they are and helps us decide if we need to ramp up our investigation. All right, so once we have a strong clinical suspicion, it's time to see the heart in action. And that brings us to our #1 tool for non-invasive risk stratification, putting the heart under a little bit of controlled pressure.
Now, you might think all exercise is created equal for a stress test, but it's really not. We use what's called dynamic isotonic exercise. Think walking on a treadmill. Why? Because it creates a volume load for the heart, forcing it to pump more blood. That's totally different from static exercise, like squeezing a hand grip, which creates a pressure load. For testing purposes, that dynamic approach is the gold standard.
And this is how we create that controlled stress safely. We use established protocols like the famous Bruce protocol you see here. It uses these defined stages, methodically cranking up the treadmill's speed and incline. Each stage asks a little more from the cardiovascular system, and that lets us watch, in a very safe way, how the heart responds as the workload gets tougher and tougher. And the result isn't a simple pass or fail. Nope. Instead, we're collecting this rich set of data with 4 key pieces of the puzzle. Their exercise capacity, which we measure in METs, their hemodynamic response, so blood pressure and heart rate, any changes on their ECG, and, so importantly, what the patient is actually feeling, their clinical symptoms.
Okay, so we've gathered all the data, now we have to make a decision. This is what I call the stratification moment, where we pull everything we've learned together into a clear, actionable prognosis for our patient.
This really is the million-dollar question, isn't it? We've got all these numbers: exercise capacity, blood pressure readings, ST changes, angina scores. How do we combine all of that into something that actually predicts their future risk in a meaningful way? Well, a huge piece of this puzzle comes straight from the ECG. ST segment depression, that's the classic sign of ischemia. But other changes are just as important. ST elevation could point to even more severe ischemia. And something called ST normalization can also be a key finding. They each tell a different part of the story. To put it all together, we use these incredibly powerful evidence-based tools like the Duke treadmill score. It's so elegant because it doesn't just look at one thing. It combines 3 of our key outputs: how long the patient lasted on the treadmill, the maximum STVation we saw, and how bad their angina got. And this right here shows you the power of that score. Let's take this example from the AHA guidelines. A 55-year-old man. He only manages 7 METs, he develops 2 millimeters of ST depression, and he has to stop because of his angina. You plug that into the score and it predicts a 4.5% annual risk of cardiovascular death. That number is a game changer. It officially puts him in a high-risk category, and that changes everything about how we manage him. So now that we've actually put a number on the risk, we can build a smart, personalized management plan. And this isn't just about writing a prescription. It's a whole strategy built on several key pillars. Therapy for chronic coronary disease really rests on these 3 pillars. The foundation for everything is lifestyle change. Diet, exercise, quitting smoking, and great patient education. The real cornerstone of treatment is what we call optimal medical therapy, or OMT. And then finally, for some very specific high-risk patients, we consider myocardial revascularization. Now, within that optimal medical therapy pillar, we've got several classes of drugs. Beta blockers, for example, are fantastic for exertional angina. Calcium channel blockers are often a go-to for vasospastic angina. The modern approach isn't about some rigid step-by-step algorithm anymore. It's about choosing the right drug for the right patient based on their specific clinical picture. And I can't overstate how important it is to get that medical therapy right. This quote from the landmark ischemia trial is fundamental. It basically found that for stable patients, even with pretty bad ischemia, jumping right to an invasive strategy like stenting or bypass was no better at preventing major heart events than just starting with and really optimizing their medications. So this leads to a really clear conclusion that's backed up by all the current guidelines. For most patients with stable CCD, we start with optimal medical therapy, period. We save the more invasive revascularization procedures for 2 specific groups. Those patients we identify as being very high risk, like our guy from the Duke treadmill score example, and those whose quality of life is still terrible from angina even after we've tried all the best medical therapies. Okay, so what's the ultimate goal of this entire process? Let's zoom out and look at the big picture of long-term care. And this idea really reframes the whole way we should think about this. Risk stratification isn't a one-and-done event. A patient's risk can change over time. Their response to therapy can change. It's a continuous loop. Assess, treat, reassess, adjust. And it's all aimed at tailoring care specifically to that individual to improve their health in the long run. And that leaves us with one final thought to chew on. We've come a really long way from just treating symptoms to actually predicting risk. The big question for the future is, with all these new therapies and deeper data insights coming out all the time, how can we make this process even more precise? How can we get even better at personalizing care so that our patients not only live longer, but they truly live better? All right, today we're going to dive.
So for nutrition and supplement management, we recommended Mediterranean style diet. When we talk about Mediterranean style diet, the EPIC study in Europe, which has several 100,000 people enrolled in it, gave them a questionnaire to classify point-wise how much how Mediterranean the diet is, and they found a 30% reduction in cardiovascular mortality if we adopted a Mediterranean diet. In brief, a Mediterranean diet implies you have meat of any kind 2 times a month, fish 2 to 3 times a week, and the remainder of the time, fruits, veggies, whole wheat bread, yogurt, and olive oil, and some dry fruits. It's recommended to keep the saturated fat less than 6% of total calories. It's recommended to minimize sodium to less than 2300 milligrams per day, optimally 1500 milligrams per day. Just to give an example, a burger at McDonald's is roughly 2000. Avoid trans fat, and the supplements that people commonly take, like omega-3s, vitamin C, D, and E, were not found to be beneficial. As a matter of fact, in a clinical trial, vitamin E was found to be deleterious or harmful. When it comes to physical activity and rehab, an exercise regimen that involves more than 150 minutes per week of moderate exercise or 75 minutes per week of high-intensity aerobic exercise is recommended. Resistance training 2 to 3 days a week, reduce sitting time, and refer to cardiac rehab for angina patients is recommended. For tobacco and substance abuse, you should assess tobacco use at every visit, advise cessation, use appropriate medications, avoid secondhand smoking, counsel routinely on substance use such as alcohol, cocaine, marijuana, crystal meth, opioids, limit intake of alcohol to 1 drink per day for women and 2 drinks per day for men. For mental health and screening, target screening for mental health for depression, anxiety, and treatment, pharmacological and non-pharmacological, reasonable. Medical therapy to reduce events includes lipid management, blood pressure management, diabetes agents, antiplatelets and anticoagulation, other pharmacologies, and angina relief. In lipid management, high-intensity statin is recommended with more than 50% LDL-C reduction, moderate intensity statin if intolerant of high intensity with 30 to 49% LDL-C reduction, monitoring with fasting lipid panel 4 to 12 weeks post-adjustment. For very high-risk patients with LDL-C greater than or equal to 70, currently the guidelines are 55, add Zetia or PCSK9 agents. For those in whom triglycerides are 150 to 499, icosapentael ethyl could be considered. The things that were found not to be beneficial include niacin, phenofibrates, and dietary omega-3 supplements. Blood pressure management, non-pharmacological strategies should come as first line for elevated blood pressure, more than 120 to 129, and the goal should be to lower it to 120 to 129 and diastolic less than 80. Non-pharmacological strategies include assess and screen for sleep apnea, recommend exercise, isometric exercise drops blood pressure more, recommend the DASH diet, which is 4 to 5 servings of fruits and veggies, restrict the sodium intake. The target blood pressure less than 130 over 80. First line drugs include ACE inhibitors, angiotensin receptor blockers, or beta blockers for compelling reasons. Diabetes agents, the ones that have been shown to give survival benefit and reduce MACE, include SGLT2 inhibitors or GLP-1 agonists for type 2 diabetics. In those with heart failure, ejection fraction less than or equal to 40%, SGLT2 inhibitors are recommended. Those with heart failure preserved ejection fraction, nowadays GLP-1 receptor agonists are gaining a role. Antiplatelets and anticoagulation include aspirin 81 milligrams daily, and post-PCI you do a dual antiplatelet agent, aspirin plus Plavix for 6 months, then a single antiplatelet agent. For post-PCI select patients, you can consider monotherapy with tricalagor, for example, to reduce bleeding. In post-MI low bleeding risk patients, you could consider extending DAPT beyond 12 months. Post-PCI on oral anticoagulants, dual antiplatelet for about a month, followed by Plavix. For those with high ischemic risk, such as those that have stents more than 5 centimeters, bifurcation stents, left main stents, prior stent thrombosis, stent implantation, the setting of acute MI. In these patients, we should consider longer dual antiplatelet therapy. For patients who meet criteria for the COMPASS trial, that is, those with CAD with PAD, CAD with diabetes, CAD with obesity, you should consider Xarelto with aspirin. And DAPT with PPI may be effective in reducing GI bleeding risk. Some agents such as Vorapaxar cause harm, and NSAIDs cause harm and should be avoided. Other pharmacological treatment, colchicine may be considered for secondary prevention to reduce events. Beta blockers in select patients, such as those with EF less than or equal to 40%, with or without MI, EF less than 50%, in the setting of a previous MI. If the MI is more than a year old, should consider discontinuing beta blockers, especially if they're causing symptoms. If there's no MI or LVEF less than 50%, beta blockers are not beneficial to reduce MACE. Renin-angiotensin receptor inhibitors, it should be considered in those with comorbidities such as hypertension, diabetes, EF less than or equal to 40%, chronic kidney disease. Without comorbidities, if EF is more than 40%, ACE inhibitors could still be considered. The HOPE trial showed in those with 2 or more risk factors for CAD, significant cardiovascular mortality benefit. Now, here's a presentation on rethinking angina.
Hey, welcome to our explainer. Today, we're digging into something called angina, that chest pain that affects millions of people. For decades, doctors have treated it using a pretty standard playbook. But what if that entire playbook is wrong? Yeah, that's the big question we're tackling today. You see, some pretty recent large-scale reviews of all the evidence are forcing a major rethink of how we manage angina. We're talking about moving away from this old one-size-fits-all model to something much more personal and, hopefully a lot more effective. Okay, so let's get right into it. Before we can really appreciate the new strategy, we need to be crystal clear on what angina actually is. It really all comes down to a simple imbalance. So at its heart, no pun intended, angina is basically a supply and demand problem. Your heart muscle, it needs a steady flow of oxygen to do its job. When you work harder, say you're climbing some stairs or exercising, it demands more oxygen. Now, if your arteries are narrowed or blocked, they just can't supply that extra oxygen fast enough. And the heart muscle, it protests. That protest is the pain or discomfort we call angina. Think of it like the heart is temporarily in an oxygen debt. Okay, so how have doctors usually tried to solve this problem? For a really long time, the approach was pretty simple and methodical. You can think of it like climbing a drug ladder. The logic here seemed really sound, right? You'd start with what everyone considered the heavy hitters, beta blockers to slow the heart rate down, or calcium channel blockers to help relax the arteries. These were your first-line defenders, and if the angina just didn't get better, you'd move up the ladder, adding on these so-called second-line drugs to try and get the symptoms under control. And this just perfectly illustrates how medicine can work sometimes. A clear, step-by-step process like this, it's easy to teach, it's easy to follow, and so it became totally ingrained as the standard of care all over the world. It made sense. But, as we're about to see, what feels intuitive isn't always backed by the hard evidence. And this is where our story takes a really sharp turn. Researchers decided to go back and just rigorously analyze all the data from decades of research to see if this drug ladder was actually built on a solid foundation. And the results were, they were surprising, to say the least. This quote right here is basically the bombshell conclusion from a massive review of the evidence. After sifting through everything, the researchers found that this whole idea of first-line and second-line drugs, it just wasn't confirmed. That hierarchy, the one that doctors had been taught for years, it just didn't hold up when they really put it under the microscope. So here's the really crucial point. When you actually compare all these different drugs head-to-head in clinical trials, no single one of them consistently comes out on top. Beta blockers weren't definitely better than, say, ranolazine. Calcium channel blockers weren't proven to be superior to nitrates. The whole idea of a first-line champion drug was basically a myth. The ladder was broken. And this, of course, raises a huge new question for everybody. I mean, if there's no simple ladder to climb anymore, how on earth do you decide where to start? How do you pick the best treatment for a patient? Well, the answer is a real paradigm shift in thinking. We're moving from a rigid one-way ladder to a much more flexible toolkit. The focus isn't on some predetermined sequence of drugs anymore. Now, it's all about the individual patient sitting right there in front of the doctor. This whole new philosophy is called tailored therapy. So instead of asking, okay, what's the next drug on the list, the question becomes, what is the best drug for this specific person? It's all about matching the right tool from the toolkit to that patient's unique physiology and all their other health conditions.
Okay, let me give you a really practical example. A patient's vital signs, their heart rate, their blood pressure, those are huge clues. So if someone comes in and their heart rate and blood pressure are both high, well, a beta blocker that lowers both of them makes perfect sense. But what about a patient who already has a low heart rate and low blood pressure? Giving them that same beta blocker could actually cause problems. In their case, a drug like ranolazine, which treats angina without messing with those vitals, suddenly becomes a much smarter first choice. See the difference?
And this personalization, it goes even deeper than that. A patient's other health conditions, what doctors call comorbidities, they're absolutely critical. So look at this table. For somebody with asthma, beta blockers can be risky, which makes other drugs a much safer bet. Or for a patient with diabetes, a drug like ranolazine can be a great choice because some beta blockers can actually hide the warning signs of low blood sugar. It is a completely different way of thinking. You're matching the tool to the patient's entire health profile. So we've got a smarter, more personalized way to choose medications. That's a huge step forward. But is that the end of the story? Or is there maybe an even bigger shift coming? Something that goes way beyond just managing symptoms with a pill? Some researchers are now asking an even more ambitious question. Instead of just treating the symptoms of coronary artery disease, can we actually reverse it? And this has led to the development of some really intensive new programs, like one with the pretty cool name Super Rehab. So Super Rehab is what's called a feasibility study. Basically, they're testing a highly structured, super intensive lifestyle program. This is designed to be way more potent than that standard advice we all get to eat better and exercise more. This is a serious cardiology-led intervention that treats lifestyle changes with the same importance as prescribing a drug. And it's built on 3 core pillars. First, high-intensity interval training, or HIIT, which is designed to really maximize your cardiovascular fitness. Second, very specific dietary advice, like cutting out refined carbs and sugars. And third, and this might be the most crucial part, behavioral change techniques to help people actually stick with the program for the long haul. And right here, this is the ultimate goal. The whole point of Super Rehab isn't just to stop the disease from getting worse, it's to actually achieve plaque regression. We're talking about shrinking the blockages that are already in the arteries. This is a huge leap from disease management to disease reversal. It is a truly revolutionary concept in cardiology. So it leaves us with a pretty fascinating final thought, doesn't it? We've journeyed from this simple but flawed drug ladder to a much more sophisticated, tailored toolkit of medications. And now we're looking towards a future where maybe the most powerful treatment of all isn't found in a pill bottle, but on a plate and a treadmill. The playbook for angina is being completely rewritten as we speak. Hey, welcome.
So, continuing, when there's a change in symptoms or function despite optimal GDMT, we should consider stress PET, SPECT, CMR, or stress echo imaging to detect ischemia and to estimate the risk. We should do invasive coronary angiography based on symptoms and results of these tests. Exercise treadmill stress test is useful to assess symptoms, functional capacity, and guide management. Coronary CT is reasonable to evaluate native coronary disease. Stent patency if the stents are large enough, more than 3.5 millimeters, and to evaluate just the bypass grafts, not necessarily the advanced native disease. Routine periodic testing for stable patients is not recommended, and it can actually cause harm. Revascularization strategies, the goals are to improve symptoms like lifestyle limiting angina, improve survival in people with left main multivessel disease plus severe LV dysfunction, lower cardiovascular events such as spontaneous MI or urgent revascularization. Decision making includes using CT correction, using FFR or IFR before PCI in angiographically intermediate stenosis. For complex CAD, a heart team approach is recommended. When you decide PCI versus CABG, patients with a high syntax score of more than 33 should be considered for bypass rather than stenting. Multivessel disease with diabetes, CABG is recommended to reduce mortality and reduce repeat revascularizations. Patients at high surgical risk, PCI would be reasonable to improve symptoms and to reduce MACE events.
Welcome to the explainer. Okay, let's just imagine for a second. Your doctor tells you you have a blocked artery in your heart. What's your first thought? It's probably fix it, get it open, right? But what if the best fix isn't a procedure at all? Today, we are diving into the really surprising truth about how we treat blocked arteries. So let's start with that big central question. You find a blockage, the gut reaction is to open it up. I mean, it just makes sense. And for decades, that was pretty much the standard way of thinking. But a whole lot of research has shown that for patients who are stable, that might not be the best move. And we're not talking about a rare thing here. It's estimated that a whopping 85% of non-emergency stent procedures, you might hear them called PCIs, are actually done on patients with what's called stable coronary artery disease. That is a huge number of invasive procedures. And that right there brings us to the million-dollar question. With so many of these procedures happening every day, what does the actual evidence tell us? Is it always necessary to go in there and open things up? Let's find out. Okay, first, let's get our terms straight. There are three main ways to tackle this. First, there's optimal medical therapy, or OMT. This isn't just one pill, it's a powerful cocktail of medications, plus diet and lifestyle changes. Then you have the procedures. PCI is the one you hear about most, placing a stent. Think of it like a plumber snaking a clogged drain. And then there's the big one, CABG, or bypass surgery. That's open heart surgery, and it's like building a whole new highway for blood to get around the traffic jam. So let's see what happens when you put an invasive procedure up against just medication. This is where the story gets really interesting. Back in 2007, a huge landmark trial called the COURAGE trial set out to answer this exact question. They took over 2,000 patients with stable heart disease and split them into two groups. One group got a stent plus all the best medicines, and the other group just got the medicines alone. And here you have it. These are the results. This graph is tracking the biggest outcomes, death or heart attack, over almost 5 years. Now look at those two lines. One is for the stent group, one is for the medicine-only group. They're practically sitting right on top of each other, almost indistinguishable. The official conclusion from the study was a bombshell. It basically said that adding a stent to the best medical therapy didn't do anything to reduce the risk of death, heart attack, or other major heart problems. When it came to preventing the absolute worst outcomes, the stent just didn't add any extra benefit. And this wasn't some brand new idea that came out of nowhere. Way back in 1983, a trial called CAS hinted at the same thing, that for a lot of stable patients, you could hold off on surgery. The COURAGE trial just drove that point home for stents, showing just how powerful modern medication can be. Okay, so if medicine is that effective, is there ever a need for a procedure? Oh, absolutely. For people with really bad symptoms or much more complicated disease, a procedure is often the right call. Which, of course, leads to the next big question. When you do need something done, which is better, a stent or a full-on bypass? So now we're talking about a head-to-head matchup. Is the simpler, less invasive stent procedure just as good as the more intensive, but maybe more durable bypass surgery? Well, the answer here is not simple at all. It turns out it almost completely depends on just how complex and widespread a person's coronary artery disease really is. To actually measure this complexity, doctors and surgeons use a tool called the syntax score. It's a system where they look at the angiogram, that's the map of the heart's arteries, and they assign points based on how many blockages there are, where they are, and if they're in tricky spots, like a major fork in the road. The higher the score, the more complex the disease.
And this chart from the syntax trial just lays it all out perfectly. What you're seeing is the rate of major problems like death, stroke, or heart attack after 5 years. For patients with simple blockages, a low syntax score, the outcomes for stents and bypass were pretty much the same. But look what happens as the disease gets more complex. For intermediate and especially for high scores, bypass surgery was significantly better. Now let's throw another really important factor into the mix: diabetes. We know that patients with diabetes often have more widespread and aggressive coronary disease, so a trial called the Freedom Trial was designed to look specifically at this group. And the results here, they were striking. This table pulls together the findings from both the Freedom Trial and from the diabetic patients within that syntax trial. And the conclusion was crystal clear. For diabetic patients with blockages in multiple arteries, bypass surgery was hands down the better option. It led to lower rates of death, heart attack, stroke, and the need to go back in for more procedures. And this was true no matter how complex the disease was. So, we've seen that for stable patients, medicine alone is often enough. And for those with more complex disease who do need a procedure, bypass often comes out on top in the long run. So, how does all this evidence actually get used when a real patient is sitting in front of a doctor? I think the biggest takeaway from all of this is that there's no single easy answer. The best treatment isn't always the newest gadget or the least invasive option. It is all about personalizing the decision, and that has led to a much more collaborative way of doing things in medicine today. This collaboration is called the HEART team. It's a whole process. First, you diagnose the problem. Then you map out the disease using tools like that syntax score. Then, a whole team of experts, cardiologists, surgeons, and others, they all get together. They talk about the patient's specific anatomy, their overall health, and just as important, what the patient wants, to come up with a shared decision that's right for that one person. And all of this brings us to one last, really thought-provoking question. We've gone through the evidence, and yet one study found that after getting a stent for stable disease, 42% of patients believed the procedure had literally just saved their life. 2/3 thought it would help them live longer. And as we saw from trials like Courage, neither of those beliefs is really supported by the data. It shows this huge gap between the scientific evidence and what we, the public, often believe. And it really makes you think about what it truly means to fix a medical problem. Thanks for watching. Welcome.
Now, special populations include those with chronic kidney disease. In these patients, you cannot do MRI with contrast. Contrast using coronary angiography or coronary CTA should be minimized or avoided. Patients with spontaneous coronary artery dissection are often young women. There can be triggers that cause this, such as delivery and during pregnancy. They should be evaluated for underlying vasculopathy, such as fibromuscular dysplasia. Beta blocker therapy may be reasonable. Doing stents in these people is tricky, if not impossible, given the extent of the dissections. There's another group of patients called ischemia with non-obstructive coronary artery disease, INOCA patients. These have positive nuclear stress tests or functional studies, but no obstructive CAD is noted. Likely microvascular angina, and we should do stratified medical therapy guided by invasive physiological testing could be considered in these patients. In young adults, comprehensive evaluation and treatment of non-traditional risk factors such as HIV, recreational drugs, inflammation should be considered. Patients with cancer need a multidisciplinary team, cardiology and oncology, to assess various drug interactions and bleeding risks. In pregnant women, a cardio-obstetric care team is recommended. Continuation of statins during pregnancy may be considered. ACE inhibitors, ARBs, allosterone antagonists all cause harm. And postmenopausal hormone replacement therapy increases risk and should be avoided, particularly increases VTE risk. In older adults, management is complicated by comorbidities and polypharmacy. We should use a geriatric framework to decide on how to treat these patients. Those with HIV and autoimmune disorders, antiretroviral therapy is beneficial to decrease cardiovascular events. We should choose statins carefully. Lovastatin and simvastatin interact with protease inhibitors. We should choose antiretroviral regimens that have favorable lipid profiles. and autoimmune disease-modifying drugs may be beneficial. Long-term use of corticosteroids is harmful. Heart transplant patients, statins are recommended for secondary prevention. Aspirin can be beneficial, and quite often these patients get sequential angiograms. So, management strategies include antiplatelet therapy, conservative versus invasive strategy, pharmacological anti-anginal therapy, advanced secondary prevention, and cardiac rehabilitation. Now, when we consider antiplatelet therapy in chronic coronary syndromes, is this secondary prevention, in which case the standard regimens that involve 6 months of DAPT followed by aspirin monotherapy. For intensified alternative regimens, you could consider extended DAPT in the high-risk patients or monotherapy with, for example, ticagrelor. We should risk stratify and individualize patients based on thrombotic and bleeding risk, and ACC-AHA calculators are available that will help you with this. PCI complexity should be considered, as we discussed earlier. Extended DAPT therapy should be considered, particularly in patients with associated peripheral vascular disease or severe disease. Ticagrelor with aspirin extended may give benefit in patients stable CAD and diabetes. This comes out of the Themis PCI research study. Those with prior MI and risk factors may also benefit from a similar strategy. If there is increased TME bleeding risk, then this should be reconsidered. Extended Plavix and aspirin could be considered in DES patients up to 30 months. The benefit is less evident in the bare metal stent cohort. For subgroups that benefit from extended DAPT, we include those with peripheral vascular disease, 2 or more implanted stents, those who had prior in-stent restenosis and high thrombotic risk features, like we discussed before, bifurcation stents, left main stents, stent length total more than 5 centimeters, stents implanted in the setting of myocardial infarction, prior stent thrombosis. There is also rising evidence for monotherapy using either Plavix or ticagrelor. Now, intensified aspirin regimens suggest that perhaps aspirin alone is not enough, and these are being investigated as well. We should always risk stratify and individualize our antiplatelet strategies. Here's a presentation, again put together by Notebook LLM, discussing this topic.
If you or someone you know has a coronary stent, you know it's a life-saving procedure. But the big question that follows is always, what's the right medication to take afterwards, and for how long? Today, we're diving into the new science that is completely changing the answers. You know, getting a stent is incredible. It opens up a blocked artery and can literally save your life. But the story doesn't stop there. The real challenge, the delicate dance, is figuring out the perfect medication balance afterwards. You need enough to stop dangerous clots, but not so much that you risk a serious bleed. So for years, the game plan after getting a stent was pretty straightforward, kind of standardized. Let's take a quick look at what that traditional treatment looked like. It was basically a two-step deal. First, for about 6 to 12 months, you'd be on something called dual antiplatelet therapy, or DAPT. Think of it as a powerful 1-2 punch. Aspirin plus a second, stronger drug to make sure platelets don't get sticky and form clots on that new stent. Then, after that initial phase, the standard move was to drop that second drug and just continue with aspirin, usually for life. But, you know, science never stands still. Researchers started asking a really important question. Is this one-size-fits-all approach really the best we can do for every single person? And that led them right here. For patients who are at a much higher risk of forming clots, is just a single daily aspirin really enough protection to prevent another heart attack down the road? And it turns out, yeah, some people are definitely at a higher risk. We're talking about folks with conditions like diabetes, people who have blockages in multiple heart arteries, anyone with a history of heart attacks, or even if the stent procedure itself was complex, maybe involving multiple stents or really long ones. So, for these high-risk individuals, the search was on. Science started looking for better, more powerful ways to keep them protected. And researchers have really zeroed in on two main alternatives. On one side, you have extended DAPT. That's simple enough. Just keep that powerful two-drug combo going for longer. The other idea is a little different. After the first few months, you drop the aspirin, but you continue with the more potent second drug all by itself. And the evidence for this stuff is pretty compelling. I mean, huge clinical trials, you may have heard names like Themis, PCI, and Pegasus, TIMI 54. They've shown that for specific high-risk groups, these more intense therapies actually do a better job preventing another heart attack or a clot in the stent. It works. But, and you knew there was going to be a but, right? This is a huge one. More power isn't a free lunch. In medicine, there's almost always a trade-off, and this one is absolutely critical. And here's the catch. While these stronger drugs are fantastic at stopping dangerous clots, they also make it harder for your blood to clot when you actually need it to, like if you get injured. This is the core dilemma, right here. You use stronger therapy and your risk of a heart attack goes down. Great. But at the same time, your risk of a major bleeding event goes way up. It's this constant balancing act, and both sides of the scale represent a really serious risk. And this is exactly why the future of care after a stent is all about personalization. It means we have to move away from a single rulebook and start tailoring the treatment to each individual patient. So how do doctors do that? Well, first, they assess what's called your ischemic risk. It's just a way of asking, how likely are you to form a dangerous clot? They look at those factors we saw earlier, like diabetes, your heart history, and whether your stent procedure was particularly complex. Then they have to weigh that against your bleeding risk. How likely are you to have a serious bleed? Key factors here are things like your age, if you have anemia or chronic kidney disease, or if you've had bleeding issues in the past. There are even special scoring tools that help doctors put a real number on this risk. In fact, one massive analysis of nearly 15,000 patients found something really interesting. It showed that when you're trying to decide how long the treatment should be, a patient's bleeding risk is often the most important factor. If that risk is high, it can completely change the game plan. Okay, so what does all this mean for you? What does this new personalized approach actually look like in practice? Well, the bottom line is we're officially shifting away from that simple everyone gets aspirin rule. Now it's all about a much more detailed, personal conversation between you and your cardiologist to find the strategy that is just right for you. It really boils down to this checklist. Your doctor is weighing your personal clotting risk against your bleeding risk. If your clotting risk is high and your bleeding risk is low, then yeah, a longer, more intense therapy might be a great idea. But if your bleeding risk is high, a shorter, less intense therapy is almost always the safer way to go, even if your clotting risk is also up there. But the science isn't stopping here. The next frontier could be something like genetic testing to understand exactly how your body processes these drugs. The ultimate goal? To one day prescribe a treatment that's not just tailored to your risk profile, but to your unique biology. Now that is the future.
Now, there's so much more to discuss in this topic. There'll be a part 2 of this video. Please consider revisiting